Good afternoon, Ms. Devine. Mr. Connell.
Thank you, my Lord. Can we go back to the witness statement, please, at 471? And I'll try and do two bits of the statement in one by linking passages. This section on that page is about the what we've heard other witnesses call the horn taps. And you say in the statement that you were aware of the outbreak in Northern Ireland, because I think babies died from what we were told.
From what I can recall, yes.
And one possible implication was that something called flow straighteners in taps had been implicated as part of the risk.
Yes.
Now, you say that you were aware of guidance by HPS, e.g. the requirement for a board water safety group and a water checklist. Were you aware that HPS had advised that taps with flow straighteners should not be used?
I don't think I was aware at the time. I did see the S-bar after that. I think Dr. Inkster shared it with me, actually.
The reason I'm asking is this has become an area of some controversy in the inquiry because, as you note a little further up the page, there's a record, there's no need to apply additional flow control facilities or remove flow straighteners, because in fact the horn tap had something like a flow straightener built into it rather than added to it. And any residual perceived or potential risk would form part of the routine management process. Were you aware of that going on at the time?
No.
Because one of the issues I think is that we've heard from other witnesses that the so-called routine management process involved thermal disinfection, which wasn't in fact done for quite a long time.
I understand that now, yes.
Yeah. The way that it's been portrayed by some with an interest in inquiry is there was a choice at the time. You had these taps which had, let's call them flow straighteners just for ease, in them. The choice was change the taps, which was going to incur a cost,
Yes.
or carry on and try and cope with it in another way. And that's been portrayed by some as money or risk. Is that a fair comment?
Yes.
And the other place that you mention this is at page 480 of your witness statement. I just want to see I can understand that. Now, in paragraph 311, you say that you had a report that in October 17, that the valves were being maintained in all high-risk areas, which may not turn out to be correct. Anyway, you said you didn't think Dr. Inkster was aware of the agreement reached, so you shared the information she had, and she said, so basically HPS and FS supported leaving these taps in. I have to say I disagree with them. Now, are you criticising Dr. Inkster for forming that view?
Not at all, no.
Thank you very much. Now, I'm going to move on to another issue that's not actually covered directly in your witness statement, but it relates to circumstances in which Dr. Valaraki was concerned with something she was being asked to sign off on, and engaged, again, the assistance of Dr. Peters as a more senior colleague. So do you remember that incident, generally speaking?
Not particularly.
Not particularly well. Well, can we look at bundle 12, 895, please? Now, I'm starting on 895 because, as in the annoying way of email chains, you end up starting at the end. If you look at the top of that page, you find Jackie Barmanroy saying, please find attached a scribe. These rooms are non-patient rooms, and so on. And then if you go on to 894, you find that that's actually addressed to IC Dr. South, so presumably at the time that was the way to do it. Pepe Valaraki comes back she sends it to Brian Jones saying, do you know about it? And Brian Jones saying, no, but on you go, is there a problem? So we just scroll up a little bit so I can see the top of that page. Yeah. Dear Pepe Valiraki says, thanks for your reply. High-level piece of work to convert into BMT accommodation under the oversight of SMT. Is this part of the scribe? Because she's obviously not sure what exactly it is. And then she says, happy to proceed, but for me to do it properly, I need to walk around the site. Now, just pausing there, that's presumably a perfectly reasonable thing for her to suggest she does. So if we go on to 893, Brian Jones says, yeah, Jackie will be able to update or assist you. And then we find Pepe Valiraki reporting that she's been up with Jackie and Christine, who's on for ICD tomorrow. Number of concerns. Air in the corridor is very dusty. There are acute leukemic patients in rooms in 4B. So dusty, in fact, I think Dr. Valiraki reported sort of coughing and so on. The vis screens meant to screen off the work, they're flapping open. There's currently work going on which is involving leak testing. So not happy to sign off the scribes given the situation as we find it, and we suggest the work stops. Now, just pausing there, if that's what Dr. Valiraki and Dr. Peters found, is there anything wrong with what they're suggesting in email?
No.
So we go on then to 892. And so this is where you come in at the foot of the page, saying to a group of people, can we meet and sort out the issues, ensure control measures are in place. You were in the ward and was happy with the ceiling, but there perhaps be more throughput. And there's a reply then from Jackie Barmanroy. Now, this seems to be controversial for two reasons. One, because there seems to be some inferred criticism of Drs. Peters and Valiraki for stopping the work when they found what they thought was an unsatisfactory situation. Now, do you associate yourself with any such criticism?
I mean, the ICDs or the microbiologists have, that if they stop the work, if they're concerned, then that's what happens.
Yep.
Especially with some of these busy screens, because they can flap. I think we use solid hoarding now rather than the screening for some of the areas. So, I mean, that's fine.
Well, the reason this is being put to you is it's said to be an example of you being deliberately uncooperative, because there are other emails which I understand we can display, although they're not yet in a bundle. Can we just have those up on the screen if they're available? Right, so can we go to the next page? So we start with an email from Jackie Barmanroy to Christine Peters saying, I've listened to your concerns, so she's the senior nurse. Discussed with Sandra, IPCD are happy to attend any meeting and walk around at the request of the hemato-oncology service. So the implication seems to be that you will attend, but only if the clinicians say so, not if Dr. Peters says so.
I would have gone if Dr. Peters had said so as well. I mean,
well, why do you think, having discussed the matter with you, Jackie Barmanroy says we'll walk around at the request of the oncology service?
I think we just wanted to ensure that the local team were cited on the requirement in terms of letting us know if the screening had come away. We wanted to make sure that they were aware, because sometimes clinical teams aren't always as aware of the importance of actually screening off some of these areas as we might be.
You can see perhaps that the recipient of that communication might think that you're saying, well, we'll do a walk round, but only if the clinicians say so. No,
I that wouldn't have been the position. I would have liked to have involved the clinical team. From what I can remember of this, and it's it was a long time ago, there was a notion that it was like a through route to a store, and people were taking the screen away and then putting it back on again. So I can't remember if it was Jackie that said that to me, that she'd gone up as well and the screen was away from where it should have been affixed to the, I don't know if it was a wall or a door. So I fully accept this. Perhaps there's not, I haven't put as much, if I've emailed information into that as possible, but I honestly think if we're asked to do something, we always do it.
Yeah. In any event, Christine Peters says, I think we need a meeting, including clinicians,
Yes.
to discuss what's going on.
Yep.
That's a reasonable response, I would suggest. Is that correct?
Yes.
And if we go on to the front page of that email, here we have you again saying, hi, Christine, Melanie's not available today, and both Brian and I have spoken to Myra and suggested the clinical service should decide how they would like to take this forward. So the implication again seems to be that you're not immediately cooperating with what ICD want, but you're
I'm sorry if that's,
shoveling it at the clinicians.
I'm sorry if that's how it seems. It was just my understanding or my recollection was that this was to do with a bit of how the clinical team were managing this work going on within a clinical area. So it's not ideal to do any work within a clinical area, and I wanted them to be cited on this. I accept that might not be as helpful as perhaps I would like to be, but that's my understanding, that we wanted to make sure the clinical team were completely cited in this.
And in fact, there was no pushback from Christine Peters about involving the clinicians, because she immediately replied saying, I agree, it's essential to have clinicians there.
Yep.
Yeah. Very well. Thank you. We can leave that. My lord, that's a document that only recently was discovered not to be in a bundle, but it will appear in a bundle in due course. And I'm obliged to the technical staff for arranging that we could display it on the screen and avoid using hard copies. Let's just move on to something else. Can we go to 478 of your witness statement? We've discussed the BMT unit, which was a late-ish instruction.
Yes.
There's also the question of the what's sometimes called the Brownlee unit, the infectious diseases unit. And you touch on that on page 478. And I wonder whether you can help us about this, because in paragraph 302, you say, we confirmed that we were waiting. And I think in some ways you were probably targeted as the author of that statement. We were waiting for information from HPS regarding the use of designated isolation rooms for patients with high consequence infections. And the question that's been asked, and I'm not sure we've had a clear answer from anyone else, is this is after, the Brownlee unit was moved in before 2015.
Yes.
So why in 2017 are you looking for advice on isolation rooms?
I think we had, again, this is my recollection of this. I recall, and I think there was a discussion at, I don't know if it was AICC or BICC, with regards to whether or not these rooms in critical care were rooms that we'd use for specifically multi-drug resistant tuberculosis and high consequence respiratory pathogens. And that Professor Williams had contacted, I don't know if it was a project team or I can't remember exactly who, but he had contacted the team to ask them whether or not these rooms were compliant for this type of patient.
Is that not the kind of information you should have known before the Brownlee unit moved in?
Perhaps,
I'm just...
Yeah, no, perhaps, I don't know what the ventilation parameters would have been for that unit, so I'm just trying to remember what it was that Professor Williams, but I had worked in Gartnavel, so I knew the configuration of the old Brownlee unit, and my understanding was that the 2 rooms in critical care would have been, you know, negative pressure isolation rooms, and that they would have been appropriate.
Yep.
I'm just trying to remember this off the top of my head, so I do apologise if any of this is not like complete.
Yeah, I think the issue that's been raised on a number of occasions, just so you're absolutely clear why I'm asking the question, is that a decision was taken to move the Brownlee unit in. Everybody knew what the Brownlee unit had, as it were,
Yes.
and could have easily found out by going there to have a look. So on the face of it, you would think it would be quite easy to work out what they needed in the new hospital. So there's some puzzlement in some quarters as to why people are still scratching their heads in 2017.
Again, this was not my area at the time, so I do apologise, and I'm not trying to be.
If you don't feel you can assist us, please just say so.
I believe that we approached our high in 16. I think this was flagged as an issue, and there was a pathway developed whereby these patients would go to Glasgow Royal Infirmary in the first instance. So there was a pathway, and from my recollection, I think it would have been Professor Williams, we had approached HPS regarding those rooms in 16. I think probably with him being away and then Dr. Inkster coming in and then Dr. Inkster not being off, it might have get sort of missed in the crossfire, but I actually don't know much more than that about that. I'm sorry.
Are you aware it became necessary to direct
Yes.
infected patients to other hospitals?
Yes.
Which obviously wasn't a satisfactory situation.
Absolutely.
And I think just for the notes, that appears at paragraph 338. We needn't go to that at the moment, but it's in your witness statement already. Can I ask you another general question? In a later section, starting on page 481, you start to touch on water issues, and you explain what you were or were not involved in. And you, I think, were not on the water technical group. No. But you, am I right in assuming that you were aware that as a sort of spin-off for the water technical group, a large group of people involving people from GGC, people from HFS, HPS, and outside experts all did a big exercise on working out what was wrong with the water system and why it was wrong?
Yes.
And produced a report dealing with that.
Yes.
Apologies for that. You were involved in some issues about decanting 2A and 2B to 6A and 4B, is that right?
Yes.
Would I be right in thinking that you were not a lead role in these? You were there to assist with things that needed done as a consequence. Is that fair?
That's correct, and to try and support the nurses on the site who were doing quite a lot of work around about this. So Mrs. Dodds was leading that, but Pamela Junides had been a paediatric infection control nurse. So we were trying to make sure that the team had all the right kind of resource in order to try and help them carry out the parts of that work that we were required to do.
Just in terms of who sorted out, what ultimately was to happen, decant, no decant, and the like, you deal with this on page 488 of your witness statement, about in the middle of the page, and you say there you recall the COO attending a meeting. You say there was a recommendation of the IMT, but you don't know who formally signed it off. Is that your position?
Yes, that's correct.
But obviously somebody very senior had been present in these discussions.
Yes.
Sure. Can we move on then? And I apologise if we're jumping around a little in topics, but it's the nature of the exercise. Everything in your witness statement becomes part of your evidence for the inquiry, even if we don't touch on it orally. On 489, we move to discuss another topic, Cryptococcus. We've heard a lot about other aspects of that, pigeons and so on, from other witnesses, which is not your particular area. But at the top of 490, you say, you've been asked what the issue with Cryptococcus were uncommon in 2 cases in a short period of time, which I think is the kind of reaction we've had from a number of witnesses. I just wanted to ask you about one thing you said on that page again, so we understand exactly what you're saying. 363, after some discussion about hypotheses and sources and so on, you say, I've been asked whether this was something I would expect to find in a new hospital. And you say, I would expect to find this in any hospital. We've heard from a lot of witnesses that Cryptococcus was extremely rare. Many of them have never heard of it in a clinical setting. Is it your position you would expect to find this in a new hospital?
Perhaps hospital was the wrong word. I would expect to find this in humans, in patients. And I hope that you'll reflect on the fact that I was part of the group that John was the chair of, so I know much more about Cryptococcus now than perhaps I did at the time. So I'm referring to the findings of John's report, sorry, Dr. Hood's report, when he has, his conclusion was that you probably won't ever know, but latency is an issue, and he, reviewed the literature and included the literature in his report round about that. Now, I know that that's not an absolutely definitive conclusion. So on that basis, what I'm trying to say is I imagine that can appear in patients or people who are immunocompromised and where this is reactivated in their system. So perhaps hospital was the wrong word.
Yeah, I simply ask because we've had evidence from a number of witnesses of very long experience, all of whom said we've never come across this in a clinical setting.
Yeah, so again, going back, so we did have a patient with Cryptococcus and RAH, and there was also a patient, I think, in fact, 2 patients in Glasgow Royal Infirmary, if my recollection serves me well. So obviously I know much more about this topic. Not that I'm an expert, but I know much more about this topic now than I did at the time.
But you, although you were involved in the Cryptococcus group, you weren't there because you had specialist knowledge of Cryptococcus. You were there to assist if things needed done. Is that again the position?
There to support John in any way that I could. I was absolutely not an expert in either Cryptococcus or in ventilation. But I think there was 1 or 2 actions that I took away from the group. I think one of them was to check whether or not 4B wanted automatic doors, things like that. So anything that I could do, I tried to do, and just support John in terms of, just make sure the papers were out. It's my PA that actually did the admin for this group as well. So I was there to just try and keep the process going and support John where I could.
And the other thing I need to ask you about there is that a suggestion's been made that you told Dr. Inkster not to talk to John Hood about this work.
Yeah.
And you deal with this on page 492 of your statement in paragraph 374. Now, you answer that by saying it's possible I would have perhaps remarked that she should let the process run its course. Is it possible that you said, don't you talk to John about this?
Absolutely not.
Dr. Inkster had a fair amount of knowledge about things like ventilation. Why would you tell her basically to keep out of this discussion?
It wasn't telling. So there's a process, and the process has been put in place. Teresa was already extremely busy, and John was, he was the chair of the group, and you know, in order just to let the process run its course in terms of basing it on his findings. I mean, I think I was trying to be helpful, to be absolutely honest, and, you know, just let that run and it'll be what it'll be and we'll deal with it when it comes back. And, you know, so it wasn't done with any intent to exclude or to prevent her from talking to John. I mean, they were in the same laboratory, so I don't agree that that was my intent.
Thank you. Now, I have a couple of other things I want to ask you, which perhaps don't appear very clearly as things you've dealt with in detail. We'll go just for convenience to 495. I'm asking you to cast your mind back, I suspect, to a meeting around June 2019, when the assertion is that, in effect, you and Jennifer Armstrong are on one side and Teresa Inkster, HPS and clinicians are on the other. And you know, she doesn't think she can rely on you for support because you're allied with a view that is against hers. Do you remember that?
I don't have that page in my screen, so I'm not sure which.
Sorry, well, it's not dealt with directly in your witness statement. I'm asking you whether you remember such an occasion.
Can I ask what the date was again, please?
I think it's probably June 2019.
And if you don't mind repeating the question, sorry.
Right. The suggestion being made is that a point came where, at least from Teresa Inkster's perspective, she was sitting on one side of a fence, which was also occupied by HPS and clinicians, and you and Jennifer Armstrong were on the other side, and she would normally expect to get some support from you because you were part of infection control, but she couldn't because you were allied with a different view about decanting and so on. Do you remember any such event?
We used to meet with Jennifer Armstrong fairly regularly, so there may have been a meeting in June. I don't particularly remember any specifics about that. What I would say is, though, that at all points I tried to support Teresa. Now, it might be that on occasions, and I think this was referenced, that perhaps, and that I would do this with any infection control doctor, you know, are we happy how we're going forward? Is there any chance it could be, maybe we could look at something else? That kind of thing. I honestly would say that, and if you consider at that point I'd moved into the ICM's role, so I was trying actually to stay away from some of the clinical issues at this point in time and try and be the infection control manager for the service, with Pamela acting into the role of, which was my job. I honestly believe that I tried to be as fair and impartial as possible and support Teresa where I was able to do. I mean, I am a registered nurse, and I do have a professional responsibility to ask those questions, even if it's just for my own clarity. So I don't believe that it would be inappropriate for me to say to Teresa, and I would hope, and I believe that all the ICDs that I work with now, if I said to them, are we sure about that? Have we had a look at this? Can we revisit that? All of them, I believe, would say yes. So I don't believe that there was a then and us. It was a group of clinical people, both infection control, Teresa, and everybody in the board, trying to work together in order to try and help get this service back on again. And so I think I don't think that's a fair representation of how I supported Teresa.
Another suggestion's been made that you and Dr. Armstrong didn't want to something treated as an outbreak because you didn't think that's what was
I absolutely
causing
disagree
it.
with that as well. I mean, I do. Everything that was flagged by any ICD was dealt with. If they thought that that was an incident, an outbreak, or even if they were just exploring the topic, it was done. I would never, ever put anyone in any kind of compromising situation or put any patients at risk by not simply going through a conversation and a process.
And you don't recollect a discussion in which one side of the conversation, represented by yourself and Dr. Armstrong, were saying, well, this isn't an outbreak at all. Some kind of background rate is acceptable. We should be looking at other hospitals.
I don't think that looking at other hospitals or trying to determine what a background rate might be is an inappropriate thing to do. I would do that tomorrow if we had an issue in a ward, especially if it was something unusual and something that was perhaps not something we had dealt with before. The first thing you do is go to the scientific literature and other centres to see what that might be. I mean, that's a normal thing to do, to try and explore the topic, to find out, you know, what additional intelligence can we bring to the table.
I think the implication is that if you go off to do that, you're not actually treating this as an outbreak at all. You're just stopping and...
I don't agree with that, I'm sorry. I really don't.
Very well. Can I ask you about something else? Just bear with me a moment. It's a quite different issue that I've been asked to raise with you. The issue here is apparently about IMTs in respect of something called mucor,
Yes,
which is an infection not the same as Cryptococcus, but in that kind of bracket. Is that right?
that's correct, yes.
Do you remember discussions about that infection arising from IMTs?
Yes,
And the suggestion is that you challenge Dr. Peters' assertion about linkage in time, place, and person. Is that right?
yes,
You did?
yes. I didn't challenge this. The word challenge has been used quite a bit, and honestly, from my point of view, I'm asking questions for clarity, and that happens all of the time, and that is a process which hopefully moves things forward. And I don't really accept that challenge is the right word there. I think it's entirely appropriate for anybody who's in an IMT to ask questions and for clarity and for queries. So I know that this word has been used. I'm not challenging their clinical expertise. I would never do that. I wouldn't do that now. What I'm asking is questions for clarity. And these two patients were in different parts of the ITU. All I said is they're in different parts of the ITU. Is this still considered to be associated with a place? And I don't think that's inappropriate. And I would do the same with any of the infection control teams.
So your position is you weren't challenging the conclusion, you were simply asking a question.
I mean, yes.
Can I guess that's something else about Cryptococcus just while we're there. 498, please. Paragraph 402, this is still talking about Cryptococcus and the various possibilities. And you say you've been asked what your opinion was, and you say you're not qualified to comment on that. Is that right?
Yes. I mean, obviously, again, I have read John's report because I've read it a number of times, but I'm still not a microbiologist, so I wouldn't feel comfortable.
Thank you. Can we see bundle 14, volume 2, 440, please? Now, I'm just asking about this because we get a slightly different slant on some of these things. You quite properly told us about, you know, the challenges of dealing with all of the issues that you had to deal with and the pressures that everybody was under and so on. But if we go down here, we find you reporting that that's Jennifer Armstrong, wants positive statements to try and ensure that public confidence is maintained. So the focus here is not so much on what's wrong and how do we fix it, but where can we find something positive to say? Is that an appropriate thing for you to be focusing on?
If there had been, so what's happening here is we're trying to pull the science that John is exploring across in order to try and, you know, ensure that the public, there are people who are sick, ill, that need treatment, who have to go into these buildings and receive care. And so if there was unpositive things to say, I would say that as well. But we were trying to say, from the work that's been done at the moment, is there anything that we can say that would provide some assurance that, you know, that work is ongoing, and if there's any conclusions to date? I mean, that's why I emailed John.
Thank you. Now, I'm not going to go through all of the IMT stuff that you've dealt with in your statement, in which you explain that one of the challenges you faced was that as matters proceeded with some of the wards, particularly 2A and so on, clinician confidence was being badly eroded, and that was obviously a challenge for you. Is that fair?
Well, I mean, I can completely understand that, yes. I mean, like I say, I totally understood where the clinicians were coming from and that their confidence in the building was not great.
Well, I want to ask you about a quite different situation now, and this is a meeting that was held at which there was a discussion in effect about Teresa Inkster's performance as chair of the IMTs. You remember that, I take it?
Yes.
Now, that's what was discussed. We know that because we've seen the minutes. Can I ask you to look at bundle 14, volume 2, 568, please? Now, this is the invite to the meeting.
Mm-hmm. Yes.
And you'll see that it starts by saying there are a number of issues regarding the hemato-oncology unit, and I'd like to take the opportunity to invite you to a meeting to discuss these, to set out the current position, discuss additional support. Now, there's not a single mention there of the conduct of the IMT chair you would accept.
Yes.
Now, let me put this to you then. Imagine a meeting was called to discuss, I don't know, infection control nurse allocation on Ward 6. You couldn't go, and it turned out that at the meeting the only topic was Sandra Devine's performance as lead ICN. You would be furious about that, would you not?
I'm not sure that this was about performance as such. I think that,
be reasonable. You've read the minutes.
I am being reasonable.
It ended with her removal.
I think it was bigger than that. It was about the process. It was about, we weren't working together as a team at this point, I don't think, like the whole IMT. And to be fair, it was a long IMT, really. Although it's been broken up into bits, it really was an IMT that almost lasted 18 months. It was hugely complicated. It was
Well, can I ask you to answer the question again? Because if there was a meeting to discuss...
Yeah, no, I wouldn't be happy if it was about my performance.
No, it wouldn't.
But what I'm saying
You'd be off
to
to
you
the
is
RCN, wouldn't you?
I'm not sure that that was about that specifically.
Well, the consequence was that Theresa Inkster was removed.
Yes.
So whatever the discussion was that led to it, that's the consequence. Now, if that had happened to you, you'd have been off complaining immediately, wouldn't you?
Absolutely, I would have been.
Now, you've told us a lot of positive things about Theresa Inkster in the context of your evidence, both written and oral.
Yeah.
Did you not think, when you were at that meeting, that you should have put your hand up and complained and said, we can't do this when she's not here?
So I thought it might be a positive thing for Theresa as well, and that's my honest opinion. I did speak to Theresa about it. Like I say, it was a long, prolonged IMT. Her responsibilities in terms of managing the chair and all of the clinical work and speaking to patients was considerable. I mean, there was a lot going on. My understanding was that, and I don't know for certain who, that a couple of people had raised concerns about the fact that the team as an IMT was not functioning particularly well, and that it is within the scope of the current guidance to have a look at this and review the functioning of the team and perhaps the chair. So I did speak to Theresa, and I honestly took it as a positive thing. I said, Theresa, maybe, it would be good for you to get a break. Maybe it would be good, to just refresh the process. Perhaps you can focus on, the clinical aspects of this, because that was her passion. That was her thing that she wanted to do. And I thought it might help. So I honestly went into this with Theresa and tried to take the positive from it as I normally do. I totally accept that. If Theresa had said to me when I spoke to her, that is absolutely, I'm not happy, that is not going to happen, I would have represented that view at that meeting. I know Dr. Inkster was invited to the meeting, and then unfortunately she couldn't go. But if she'd actually said to me that is just inappropriate, I'm not happy with that, I would have said that at the meeting.
I mean, are you actually asking us to accept that you sat during that meeting, the consequence of which was she was removed as IMT chair, and you thought that was a positive?
Yeah.
And you never thought, given your respect for her, that you should say it was inappropriate to do it at all when she wasn't there?
Perhaps in reflection, I should have done that. It was a very, it was quite a senior meeting. I was a relatively inexperienced manager in terms of infection control, the bigger picture. I honestly believe that if Theresa had said to me, I'm not happy with that I would have said at that meeting.
Well, she never got the chance to do that because she wasn't there and the decision was made.
No, absolutely.
When we're talking about that meeting, I think I'm understanding it as actually the IMT of the 23rd of August as opposed to the meeting on the 20th of August.
Well, the decision was made at the meeting of the 20th, but the date on which it became effective was the next IMT on the 23rd.
So which meeting are we talking about?
So the decision to remove Theresa Inkster was made at the meeting on the 20th.
20th, yeah.
Because by the 23rd, there was another chair in place. Is that right?
Yeah, I mean, so we're not at cross purposes. I mean, when Mr. Connell was using the expression, that meeting to you, you understood that as the meeting on the 20th.
20th,
Yeah. Thank you.
So what then happens, of course, is that there's a meeting on the 23rd at which you have the rather odd situation of Theresa Inkster having to turn up at a meeting of an IMT having just been removed without any discussion with her. Is that right?
It wasn't as straightforward as that, I'm sorry. So this meeting took place on a Tuesday, and Dr. Inkster had gone off sick. Dr. Peters had let me know that Dr. Inkster didn't want to be contacted under any circumstance. I mean, I was anxious that I hadn't spoken to her. I mean, I really was. So Teresa was off from the Tuesday.
So that's after the meeting of the 20th, so His Lordship understands. Yes.
So Teresa was off from the Tuesday, and we were asked not to contact her. When I left that meeting, my interpretation was that until we'd spoken to Teresa, that Teresa was still the chair of the IMT, because that was one of the actions, and I thought that was completely appropriate and respectful of her position. What happened after that was that over the course of the Wednesday and the Thursday, I tried to get one of her colleagues to step into the IMT on the Friday on her behalf. So I approached two of the infection control doctors at the South, who both felt, and I completely understood why, that it was too complicated an IMT for someone to step into. And then I approached Professor Jones on the Thursday as well to see if he would chair it on her behalf, on Teresa's behalf. So I get to Thursday, and I think I contact Jennifer Armstrong to say, I'm really sorry, but we don't seem to have a chair for tomorrow. Now, my instinct at that point would have been to try and move that IMT a wee bit forward, maybe into the next week. However, at this point in time, we had diverted children to both Edinburgh and Aberdeen, and it was felt that it was too important a meeting for it not to go ahead. Now, it's my understanding, and I'm sure she would have told me that Dr. Armstrong had approached Linda DeCastica to ask about a public health consultant to chair that meeting. And again, you can get infection control doctors, consultant, public health. So what happened was Alison Balfour, sort of late in the Thursday, said to me that Dr. Inkster might be back on the Friday. So I emailed Dr. Inkster that night and said, just to let you know, Teresa, the IMT is tomorrow and there's a pre-meet at 9:15. Now, I can't prove this and I don't completely recollect it, but I imagine I would have tried to contact Teresa a couple of times on the Friday morning, because that would have been a thing that I would have done. Because as I said to you, I was fairly anxious about the fact that I hadn't spoken to her. I had hoped that Teresa would have attended the pre-meet, but she emailed me to say that she was caught up with some results and that she would be late to the pre-meet. So I hoped that Teresa would have gone to the pre-meet, and then that might have been the opportunity to have a more formal discussion about that. But obviously that opportunity didn't arise, and I'm regret. It wouldn't have been something that I would have thought was a great example of a process going forward, but it wasn't intentional, certainly, that she wouldn't have known about it.
Well, I can understand why you say that, but by that time the decision had been taken. So discussion with her effectively amounted to telling her why she was being removed. She didn't have any say in it, did she?
Well, I don't accept that. If Teresa had come to that meeting, because I tried to get one of her colleagues, so in my head, until we'd had that conversation with Teresa, she, up until that point, when events kind of overtook itself in terms of Amelia Crichton being the chair, I was still trying to kind of work the time where I could actually speak to Teresa about it. I didn't think she was completely negative about it. As I say, I would have represented that on the Tuesday if that had been the case. And honestly, if Teresa had come in on the Friday and said, I am totally not happy about this, then I think there would have been a conversation that might have changed that in some way, but I didn't get that opportunity, and nor did anyone else. And I do regret how that all played out.
Yeah. In your witness statement, you say the decision was made on 20th August 19 to change the chair.
Yeah.
So the decision had been made.
It was me, but I would still have backed Teresa up if she'd really, you know, if she'd wanted to go back and revisit that, I would have assisted, supported, and supported that process.
Let's have a look at bundle 27, volume 11, page 101, please. Now, this is an email from NSS in which they are trying to summarize what happened at an IMT. I don't think we just have the date immediately there, but we'll pick it up in a minute from the previous page. So go back to 101. What NSS say, fairly near the bottom of that, maybe 3/4 of the way down that page, NHS GGC have replaced the IMT chair from the lead ICD to NHS GGC Deputy Director of Public Health. So that's their take on what's been done. You then challenged that, didn't you?
I did.
So if we go to 100, you go to them and you say, Chair agreed to be replaced in order for her to have time to review incident results and actions. That's not correct, is it?
That I could have only said that if that had been the impression that I had got from the meeting with Teresa on the Monday.
You didn't have any information to make that statement. Teresa Inkster didn't agree.
I absolutely agree. I overstated her position, and I regret it. It was. I looked at this, I think it was yesterday, and I thought, I agree. I overstepped or overstated what I thought her position would be, and I absolutely agree that was not appropriate.
Because what then happens is at 107, NSS come back to you and just carry on down till we see the content. They say, well, our reference to the chair was a factual statement made for information. So that they're saying, well, whatever you're saying, what was said at the meeting was she's been replaced, which is correct, isn't it?
Yes.
And in fact, if we go to 99, we then find the consequence of your having stated what you stated, which is that Teresa Inkster felt it necessary to tell a large number of people that she didn't agree to be replaced to review incident results and actions. And in fact, she goes on to say that she was asked to demit due to feedback from everyone, as that was put to her, that the meeting was difficult. However, this was not corroborated at the IMT today, being the 23rd, by senior clinicians, HPS, or the microbiologists. So she doesn't even think everybody was agreed that there was a problem.
I understand that, yes.
And she then got in touch with you to seek an explanation, did she not?
She did, yes.
Like we have bundle 14, volume 2, 570. Now, you were asked in your witness statement whether Teresa Inkster got in touch with you, and you said you'd no recollection of it. Do you not remember getting this communication?
I'm sorry, I didn't at the time. I do apologise.
Did you ever reply to it?
I don't believe I did. What I think that I did was go and see Teresa, because Teresa was still our lead ICD, and for the days preceding this, I was in communication with her about trying to ensure that her diary supported the next IMT, and trying to make sure that both her and Amelia were available to ensure that obviously she was included in the process. So from that point of view, I believe I went over to speak to Teresa directly. I don't remember responding to this email. Perhaps I should have done in writing, but my recollection is that after that, Teresa was our ICD, and I went over and I'm sure I went over and spoke to her about it.
Because one of the particular points she's raising there is that having had the meeting on the 23rd, she felt it was clear that not everyone was saying that the problem was the chair, in effect, that others, such as clinicians and microbiology colleagues, were not necessarily pointing the finger at her and the need to change the chair as the problem. You see that?
Yes. As I said, my simplistic interpretation was that the whole IMT wasn't really taking anything forward. We were lacking kind of focus. As I said, it was very complicated. There was lots of things playing into it. There was loads of media attention. The clinicians weren't happy. The kids had been diverted to other hospitals. It was just about trying to make the process function again so that we could come to a conclusion, whatever that might be, in terms of a way forward. And I think that's why there was negative feedback about the IMT. I mean, for me, it's just about, I'm really sorry, I don't mean to be flippant about this. For me, it's not about personalities and things, it's about trying to find solutions to an issue in order that services are available to patients. Maybe that's, maybe that's my lack in emotional intelligence, but for me, it's just about this isn't working, how can we fix it and can we make it better? And I honestly thought that Teresa being the lead clinician for IPC and doing that kind of clinical work would perhaps take some of the pressure off of her and perhaps make this process go forward a wee bit. That is my honest answer.
Were you surprised that she was upset about it?
I was a bit, yes. Like I say, maybe it was my fault. Maybe I just pitched it as a positive thing, and that it might be a good thing. And like I say, for me, it was just about trying to move things forward, and it just felt like a refresh, or maybe just taking a step back. It was really difficult to just sort of say, can we take a step back and just have a wee look at this and try and figure out, what's going on? Can we refresh this? Can we reset things? And it is within the spirit of the existing guidance that, if you have a prolonged IMT, that perhaps you should think about a chair and a deputy chair, or maybe having another ICD carry this role forward, with the ICD with the responsibility for the clinical service perhaps being a part of it. So it didn't seem like it was out of the ballpark in terms of a reasonable thing to consider and to do. I absolutely understand that Teresa wasn't happy about it. I totally take that on board. It was almost like it was a bad combination of circumstances. It's not how I would have. It's not what I wasn't happy about the rapidity and the conversations up to that point.
Can I ask you then about a totally different issue? In the course of the whistleblowing exercises that went on, you had some involvement in that, did you? Particularly in relation to Dr. Redding?
Yes.
Maybe, it's been suggested you may be able to help us with this. Please tell me if you can't. Can we have a look at bundle 27, page 81, please? I think.
Sorry, which volume?
That's a good question. I thought I had a note of that. I don't. Try volume 1. It's part of the whistleblowing report into Dr. Redding. I'll leave the point more. I can't immediately identify the reference. The question that's been raised is that there's a reference in the whistleblowing exchanges about Dr. Redding to air change rates and to an SBAR that had been prepared,
Yep.
I think, by Dr. Inkster. And I think the question is, does the discussion in the whistleblowing report accurately reflect what Dr. Inkster said in the SBAR?
Obviously, I don't.
Can we have a look at that bundle 4, page 52?
I mean, it is a fact that there should have been 6 air changes and there were 3. I mean, that's all. That's correct.
Yeah. I think the question is whether somewhere in this exercise, what had been said in this SBAR got diluted or changed by the time it found its way into the report.
I don't believe I ever saw that during that. I was just interviewed.
So you can't really help us about how that was done?
So, sorry.
Okay, thank you. Right, let's go on to a different topic. I'd like your thoughts on a new insight that we had from another witness. You're asked at page 517 of your witness statement about communications generally, and you're not the communications specialist, so we'll have other questions for them in due course. But you'll see in paragraph 478, there's a discussion about what information parents are getting, and you agree that it's obviously emotive if it's their child, and who could disagree with that statement? In the course of his evidence, Dr. Mathers offered the suggestion that you don't ask the person who drafted the communication whether it was effective. You look at it from the perspective of the recipient. In this case, it would be largely parents. Do you think that's a useful insight?
I think there's a real art to the best form of communication is clinician to patient or parent in this thing, because that's the only way that you can gauge how much information that someone might like, and it leads you down to have sort of conversations. Drafting information is a skill, because you're trying to balance the information with, does it make sense? Are you using jargon? Does it not? In terms of trying to gauge a wide scope of different people and communicating well with them. So his point is probably well made. It's whether or not the person that gets that information is happy with it, but there was a lot of that information produced, but it was produced in line with communication with parents and patients at that time as well. I think the best way to communicate with patients is directly, but in certain circumstances you do need to draft comms to back up what you're saying or what you're trying to communicate.
Yeah. Just so I'm clear, that's quite a long answer to what I'd originally intended to be a short question. I don't criticise you for that, but I'm just keen to understand your response to the point. I think what Dr. Mathers was trying to get at was, don't ask the comms lady or the doctor or whatever whether their communication has been effective. Ask the parent, because it's the parent will decide whether that was an effective communication. And did I understand you said that's a point well made?
Yeah, it is a point well made. However, sometimes you do need colleagues. I mean, we do it when we make patient information leaflets. We send it out to a group who look at it from a patient's perspective, put it into kind of, I think they call it like plain English and things like that. So there is a certain amount of skill in order to do that as well. But I mean, he is right. I mean, the only people who can really judge how effective it is are the people who receive that type of information. But I'd have to say that one person might say, yeah, that was great, that was enough, and the next person might say, you know, no, it wasn't. So that's what I'm saying, it's really difficult to draft lines that are going to hit the mark for everybody that receives them.
The other question you mentioned in the course of your earlier answer was that the best communication is direct from the clinician. One can readily understand that in the context of discussion about the patient's treatment, prognosis, you know, and that kind of stuff. Obviously, the person to have that conversation is the clinician. The question that's been raised is if the issue is nothing to do with the person's cancer or whatever, nothing to do with which drugs might be most effective, but it's all about whether the environment that the hospital has provided for this to take place in is safe, adequate, whatever phrase you want to use. Would that not be the responsibility of other management to communicate that rather than burdening the clinicians?
I think it's a kind of a collaborative process. So, so Jamie Redfern was the general manager at that time, and Jennifer Rogers was the chief nurse. So you've got a kind of combination of a manager and a nurse, and sometimes that works, and sometimes patients would prefer to speak to a nurse or an infection control nurse. I know that Dr. Inkster spent quite a lot of time in that area with clinicians, because the best way to do that is probably with both of them. So because patients are going to have questions like, but how does that impact on my treatment? So it can be quite a complicated situation, and is best sort of trying to target the individual patient and their needs in order to get the right things. Now, again, I know that's a long answer, but it depends on the patient, the situation, the clinician. It depends on lots of things. And it's a process that, you know, I think everybody tries to contribute their best to that, but it's not straightforward.
I suppose that the thing I'm trying to get at, perhaps not very well, is that if the clinician is talking about the cancer treatment, say, just keep it simple, and the patient asks a question about the cancer treatment, chances are the clinician knows the answer, or if they don't, if it's perhaps a more junior clinician, they know who does, and they can go and get the answer. If the question is about, you know, the ventilation or the water system or whatever, that's not their specialism. So if they're asked a question, they won't necessarily know the answer.
But that's a very unusual circumstance. So I'm just going back to it as an example. When we had the outbreak of MRSA in the burns unit, the clinicians, after being at the IMT, were quite happy to communicate to the patients as their primary clinician. They understood, you know, the actions that we were taking around the IMT and what they were telling patients. Absolutely, except when it's water and ventilation. But that wasn't a normal IMT. It wasn't a normal incident.
But if I take your example, if people had been in the burns unit for a prolonged period, for the sake of argument, and there was an issue as to whether the ventilation needed to be improved, in order to improve this patient safety element, the clinicians wouldn't necessarily be involved, would they, in the whys and wherefores of when that work might or might not be done, and therefore wouldn't be able to deal with that.
I know, but when clinicians feel like that, then they reach out to us and we will send someone to help with that conversation if that's what they want. So the clinician might have a chat with the patient and they understand and they're happy, and another patient might say, no, I want more information. And then if a clinician feels that he or she is not able to give that information, then they would phone and we would come and help that process.
Just some pieces of information, perhaps. In page 518, you're asked about the duty of candor, and you're talking about duty of candour in the context of IMTs. And then you say in 484, there's a module regarding duty of candour on LearnPro. That's presumably your online learning system, is that right?
Yes.
Then perhaps to the surprise of some, you say it's not a mandatory module.
That's correct.
Should it be a mandatory module, duty of candour?
Well, from my point of view, yes. But it was relatively new in terms of legislation. And so from that point of view, yes, it might be that not everybody needs to do a module on duty of candour. So you wouldn't really expect, so mandatory training applies to everyone. So you wouldn't really expect domestic staff or portering staff or to you know.
You may have to say who it's mandatory for.
Yes, so we do infection control education, and we have a kind of grid at the back of the education strategy, and we have groups of staff, and there's mandatory education, and then we've got suggested modules that we think in terms of your clinical practice that we would say that these would be modules that you should complete. So mandatory is there's always a thing about mandatory because it's a kind of blanket for everybody, and sometimes it's not absolutely appropriate for it to be everyone, but the trick is trying to do these groups of staff, but it would take someone like me to say everybody in the team needs to do the duty of candour module, and then that's how that would be managed locally.
The next section of your report, you asked briefly about whistleblowing. It's been suggested to the inquiry by another witness that the real attitude to whistleblowing in many quarters is that it's not really approved of, it's not regarded as something professional to do. Do you have a view on that?
I mean, it absolutely has its place. I think it's a positive thing. Generally, I think what you would expect is for people to try and exhaust every way through their own systems in order to have their voice heard. But at the end of the day, if they feel that their option is to undertake whistleblowing, then I fully support anybody's right to do that.
Again, some further points of detail. At page 525, you pick up on one of the case note review recommendations. And am I right in understanding that the database that you refer to there, database of microbiological results,
Yes.
has been developed and is in place?
Yes.
And am I also right in thinking that a form of root cause analysis is now done in certain wards?
Yes. So I'm going to be pedantic here. I prefer to call it a clinical review. It was referred to in the IMT minutes as a root cause analysis, but a root cause analysis, if you speak to colleagues in clinical governance, it's a much larger process. What is in place is what I would say a clinical review of the cases. Now, we were asked to implement that in Ward 2A, but we have also put that in place for PICU and the NICU. So the NICU and the Queen Elizabeth, we've actually just rolled it out to the NICU and PRM and the RAH as well.
Sorry, my fault entirely. I'm not sure if I really absorbed that. Do we have a starting place in relation to root cause analysis? Do we have a starting point in the statement?
If we go to 530, I'm obliged to the witness for the explanation because that was going to be the next question. That people talk about root cause analysis. There's been some discussion about root cause analysis, but what you're explaining is that what's actually done is not, to your understanding, strictly root cause analysis. It's a slightly different system. Is that right?
It's a clinical review of the patient. And at the end of it, which has been really helpful, is the infection control team with the clinician come together and they say, looking at all of the information that we collected, where do we think the source of this infection might have originated from? Sometimes you don't know. Sometimes it's quite clear. Patient has maybe another infection at that time, or there are quite interesting things that come through from the clinical review that you perhaps might not have thought about.
So the sort of short version is that having been asked to do root cause analysis, you're doing a clinical review and you find that useful.
Yes.
Earlier in your evidence, I asked you about some attempt you made to look at the rates of the 3 infections, C. diff, Staph aureus, and E. coli,
Yep.
in 2019. And I think you've been asked in your witness statement whether you are the author of something called a summary of patient safety indicators.
Yes.
That was attached to a board paper. I think it might be helpful to His Lordship in particular, at least if we look at this, because you confirmed that you, at least nominally, are the author of it.
Yes.
Can I just ask you, when you're described as the author of it, I mean, you're not an epidemiologist. Did you get the material, or do you just find it somewhere else?
No, I just sourced it from different places. I was asked just to do what data do we have, what information do we have. So I used the HPS report, I used the output from prevalence.
Sorry, could I ask you just to go back on that? At dictation speed, what were you asked to do?
Just to try and gather any information about the entire campus in terms of an indicator to see if they were in any way unusual.
Right.
So just pausing on that while His Lordship makes that note, you made the point in your witness statement where this is dealt with at page 529, that this was a summary of the available data you had, and in no way was it supposed to refer to 2A or 6A or any particular ward. It's the whole campus.
Yeah, it was the whole campus.
And where did you get the information from?
Well, the point prevalence study is published, as was the R-High review. I got some information from clinical governance. I'm going to forget what this is. So they have data on expected number of deaths in I think it's called HMSR data. So they we're monitored, all the different hospitals within the board, of what an expected death rate might be, and then they basically say whether or not you're an exception, so back to kind of using charts, or whether or not your expected rate is under the national average. I'm sorry, I'm not explaining that very well, but so there are bits and pieces of data within the board that you can. So I embedded a paper from clinical governance in the main paper. So that wasn't my work, it was clinical governance work that described this type of data as well. It was just a putting together of what we had in the absence of having sort of more robust data in terms of 2AB. Really, the only data we had for 2AB or 6A at that time was the R-High report.
Well, let's just have a look at it, in particular at the charts. If we go to bundle 25 at page 345, so we have the positioning paper. So I'm not wanting the positioning paper, but if we scroll through it, we come to the appendix to the positioning paper. Carry on, please. No, keep going. It should be at the end, logically. This is this all stuff that you put together, or did you just lift it from somewhere else?
I think I drafted the paper, but most of it would have been sourced from whatever available source there was. We had to look at it. So the National Regional Services, obviously that's not in any way controversial. What I think I was trying to demonstrate there is it is an unusual site. I absolutely think that. So all of our high-risk patients in the west of Scotland probably are on that site. So renal inpatient services, the bone marrow transplant for both adult and children, so ID unit. So there is a lot of high-risk services within that unit, and that's described in the RHI, in the manual, in the national manual, about it's actually where you test for Pseudomonas, and I think almost everything listed in the national manual, service-wise, is on that campus somewhere. I think the one that isn't is cardiac surgery, is at the Golden Jubilee, but a lot of our most vulnerable patients are on that site. So I think I was putting that in to try and balance the risk in terms of the types of patients that are accessing services in there, especially in the children's hospital, actually, where they've got regional and national services. So all of my interpretation is all of our sickest, there's sick patients everywhere, there's immunocompromised patients everywhere. I don't mean that to sound like that, it's just there is a collection of high-risk patients within that site that I think leaves them, they are more vulnerable.
So if we just scroll on from that page, which is 364, just for ease of reference, then you've touched on social deprivation. Yep. If we go on past that, there should be some graphs further on. And you've picked up on various reports and some figures. Mm. Can we just go back one page, the 372 summary? You say the data presented show that QEUH had lower rates of hospital-acquired infection than other hospitals in Scotland. Now, what infections were you able to produce material for? Is it not the same three we talked about?
That's a point prevalence study.
Oh, that's a point prevalence study, right. So we go on, I think did you attach some graphs to this?
Might be, yeah.
So what you then have are, there's a graph about Staph aureus, is that right?
Yes.
And perhaps the quirky bit about that graph is that the latter section has changed to look at only cases that are labelled as healthcare associated. Yes. Is that right?
Yes.
And in fact, that appears to suggest that the hospital is doing not so well in that respect. Is that right? Because you're above the line consistently.
Right. So we don't have hospital-specific data. That's why we asked RHI to do the analysis of RHC. So this is data for all of Glasgow and Clyde.
A whole of Glasgow and Clyde, right.
So okay. The rates were, and the definition changed to being only hospital associated. So they changed the definitions within the national surveillance system, and that's what that is demonstrating. And actually, if you look at it, it's starting to sort of cluster around about the sort of central line there. And we've spent many years trying to drive down the rates of Staph aureus bacteremia. I mean, it's a very serious bloodstream infection, and we continue to do that now. We've got local reduction groups all over the board, but thankfully, to a certain extent, all of the things that we could do are in place now, and we continue to try and drive this particular infection down. But over time, the big actions that you take start to, they're in place, and then you're looking at sort of more subtle ways to try and drive that particular rate down.
So that deals with Staph aureus for the whole board?
Mm-hmm. Absolutely, yeah, because I don't have hospital-specific data. This is national data. I wanted to use what was available in the national.
And do we see graphs for the other two infections as well?
Yep.
C. diff, I think, will come up shortly. Yeah, there we are, page 376, where you're being charted against a target, is that right?
Yes.
The target being broadly the dotted line?
Yes.
So there's an aim to try and bring this down as well, and you're being tested against that?
Yeah, I mean, although we are talking about incidents and outbreaks, the main body of the work, especially probably with the nursing team, is trying to put actions in place to try and reduce. These are good indicators in general. It's about, I'm hoping that, I hope this demonstrates that in terms of practice, we've been moving forward and changing things as we go, and these are the results. So these are the indicators that the Scottish Government use for boards in order to try and use some matrices for performance. They just happened to pick these three out. Obviously, C. diff was a very serious infection at one point in time, so you can see that the drive was quite clear to try and reduce this, but it's all about trying to reduce infections in lots of different patients over time.
And this is the infection, these are the rates for the whole of the board.
Yes.
And this is the particular infection that you said when asked much earlier in your evidence, you would have expected to be able to bring down in the new hospital because of the way it was set up.
C. diff, yes.
And if for completeness, there's another one for E. coli, again for the whole of the board.
E. coli is much more tricky to try and reduce because most, there's a lot of community cases of E. coli bacteremia, and with Staph aureus bacteremia, you can kind of focus on line care. With E. coli, the source of the bacteria seeding into the bloodstream can be a urinary catheter or gallbladder disease, or it's much less tangible in terms of actions that you can take to try and bring it down. So this is a relatively, compared to the other two targets, this is a new target. I say new, it's probably been in place for maybe about, I'm guessing maybe 6 or 7 years, but the C. diff target and the Staph aureus target have been in place since 2006-07, something like that. But the actions that you can take in order to drive down E. coli bacteremia are much more tricky. And actually, we're just expecting some communication from the government at the moment about modifying this target to actually make it less challenging, because there isn't a board in Scotland that's actually meeting the E. coli bacteremia target, as far as I remember.
These graphs show what are described as healthcare associated cases.
Yes. So that's any contact with any healthcare environment in the previous 30 days. So it can be anything. It could be a dentist, a GP, if you're in a care home, for example. Quite a lot of E. coli bacteremia are associated with elderly patients as well. So these are healthcare associated.
But again, these are figures for the whole board.
For the whole board, yeah.
Not.
I wanted to use the data that was validated by RHI.
Yes.
For what purpose?
I think it was just to try and to highlight that in terms of performance against the standards, that the board as a whole, I wanted to demonstrate that infection control as a service strives to try and bring healthcare associated infection down. All I was trying to do with this was just to try and demonstrate that our focus is on healthcare infections generally, and that we were successful to a certain extent in some of these indicators.
Right. Successful in the sense that the,
Apart from E. coli.
at least for some of, is it true for all of the infections that there are a downward trend?
Yeah. Well, the E. coli bacteremia is bobbing about really around the mean, so perhaps not for the E. coli bacteremia, but we actually have work streams in play at the moment to try and
Sorry,
reduce.
you have that?
We have work streams in place with different groups at the moment to try and reduce this too.
Right. So the purpose was or the result was to demonstrate that for the whole board in respect of
Practice.
two infections, Staph aureus and C. difficile,
yeah.
there's a downward trend over the periods that these infections have been monitored.
Yes.
Sorry, Mr. Connell.
No, I don't think I have anything further to ask you about these graphs. Thank you very much. I really need to move, I think, to the concluding sections of your witness statement. You've made very positive comments, for instance, about Ward 2A and its newly refurbished form. Can I just ask you about page 537 of your witness statement in paragraph 546? You mention something called the Key Stage Assurance Review, which is I was about to say an NSS process. I'll probably not get the labels correct. But the point I wanted to ask you about in particular was a bit in the middle of that paragraph, where you say there's an expectation that IPC have input at all stages. This is unachievable. Now, why do you say that?
The resource in terms of this process is intense. I have an ICD in the north who is working on, there's a big northeast hub, it's a big community type, dentists, GPs, social work. It's a big centre in the East End of Glasgow, and she has spent weeks and weeks of her time making sure that all of the key stage assurance processes are in place. It has taken up a tremendous amount of clinical time, especially actually, no, the ICNs as well, but there's more ICNs. But in terms of the ICDs, it has taken up quite a lot of their time. And to be fair to the ICDs, some of them are interested in building projects as such, but their passion is clinical care and research and that interaction with clinical teams and patient care. So to a certain extent, this is, it's quite interesting. I mean, I find the building work interesting, but it has taken up a significant amount of clinical time. And IPC is a scarce resource. I mean, someone could give me, I don't know, loads of money tomorrow and I couldn't recruit to the posts because the ICDs literally are so skilled now that it takes quite a long time for them to become ICDs. They're all consultant microbiologists. And even the nurses, the pathway from a trainee ICN to a lead ICN will take 4 or 5 years. So, and in addition to that, so we've got this going on. So during COVID, there was a message that went down to the nurse directors to say that they would take, I don't think it's responsibility, but they would sort of have under their remit nursing and care homes. So suddenly we had to put a team together in order to support infection control and care in nursing homes. And there's 160 care homes across Glasgow and Clyde. So there's that remit, and then you kind of get into, GPs might have to use FFP3 masks, and who's going to sort of train on that. So the scope of the team is getting larger and larger, and the team can't get larger and larger at the pace that the expectation is round about what they've got to deliver.
As a matter of principle, would you agree that it's desirable to have infection control at the heart of building projects?
Absolutely.
Given the implications for patient safety?
Yes, absolutely. But what I would say is, and this is way back in history, I seem to remember a long time ago, and it was a long time ago, that there was a department within, I think it was the Common Services Agency, and they were the people who consulted on any new hospitals. So all the expertise were there. There were nurses, doctors, engineers, all sorts of people within this department who, if you had a new build, would come in partnership and give advice and tell you how to build this. So for me, I mean, our team had quite a lot of experience in this, but I think if I was in a smaller board and perhaps never approached the building project before, it would be quite daunting, even just to getting up to speed with all the building notes. So I guess our hope was that if you were going to build, so to build a hospital in Lanarkshire, you learn all the lessons from that, and then you take that and you give advice when we were building the same hospital in Glasgow. You know, it doesn't make sense to me, I don't think, that we have, you know, all of this expertise within NSS, and yet the responsibility for new builds lies with teams who may not have that experience or background. It just doesn't seem a sensible thing to do when that expertise is there. And that's only my opinion. And I think the anticipation when NHS Assure came to was that they would tell us how to build these buildings, and we would be partners in that and participate in the process, and especially around about things like the burns unit or sort of clinical areas, or perhaps a clinical team is anticipating doing some kind of different type of invasive procedure, then you could input into the process. What is happening is that we are the input and the advice, and then that process is assured. And I think, certainly personally, I had hoped that there would be a central place that you could go and say, we're going to build a North East hub, you know, tell us what you think should be in the building.
So,
Now that was
Slow it up, slow.
delivered at quite high speed. And I'm interested in your views on this matter. What you're reflecting on is the initiative, which is NHS Scotland Assure.
Yes.
Limited number of years of experience, just since 2021. But what I was picking up from what you were saying, there was a sense of disappointment, or and can I just sort of capture that again at dictation speed?
I think for me, it's about the logic of it. If you have that expertise within Scotland and a board is going to build a new hospital, it would seem logical to me that the people who might have done a number of these builds take that knowledge and bring it to the next board that's going to build a hospital, in order that you're not repeating this process all of the time. So at the moment, like, for example, our ICDs, if it was an unusual build, we'd have to go away and research the building notes and about ventilation or water or, you know, all these kind of things. And then they make judgments or give advice to the project team based on that. It just seems to be logical if that, from my simple point of view, I kind of think that if you're going to build a North East hub, you should be able to lift a manual off the shelf and say, we built that in Grampian, this is the best way to do that. I mean, absolutely accepting that there's new innovations and technologies and things like that, but it would seem logical to me that if you built it in one board, that you should be able to take that template and do it somewhere else, and that if we have a repository of expertise and lessons learned in a national forum, that it just seems sensible, instead of diverting infection control teams in order to do that from scratch up, when really, you know, that service, I think I'd hoped that that's how that service would work.
And I take it from what you say that would involve the central resource, which at the moment is NHS Assure,
Even
being responsible for the design
Yes.
and supervision of construction.
Yes.
Thank you.
because I think the consequence of the point His Lordship has just put to you is probably that all of this would be pointless if, you know, a board said, well, that's very interesting. We've been told how to build this health centre because Grampian did it so well, but actually we want a cheap and cheerful one, so we'll not bother putting in A, B, and C. There would have to be some kind of mechanism if you were going to go down that route of assuring that the best practice was actually applied.
Absolutely, and that would be the standard.
Well, let me just ask you, I think, about one final matter. in your witness statement, in the closing sections, you set out your unhappiness with a lot of things that happened.
Yeah.
And as I noted it, and I may have got, no doubt I'll miss somebody out, you weren't happy with the oversight board, you weren't happy with the case note review, you weren't happy with politicians, you weren't happy with Scottish Government officials, you weren't happy with officials in the government agencies. So in effect, they were all wrong and you were right. Is that really what you're telling us?
No.
Because you're clearly not happy with the fact that what you portray as the board's position has not been accepted by a range of bodies.
It didn't feel like a fair process. I have spent my entire career trying to do the right thing, trying to support clinical teams in the front line, focus completely on patients. All of my team do the same thing. And it felt like a really, it wasn't based on an open assessment of the situation. Now, that's my personal view. I went up to the oversight board and we were giving presentations, and I felt we were making a really good, we had a forensic accountant go through all of our systems and processes. We had the independent review. I mean, there wasn't, to a certain extent, there was almost a part of me that wanted them to find something so we could fix it. But we had all of these processes and it just didn't feel like it was an open and fair evaluation of the evidence in front of them. It just didn't feel like that. And it honestly, over the last, I mean, it's 5 years now. I mean, it's been a real trying to keep everybody together and everybody supported. We went through COVID as well, with everything going on, and then not feeling as if you had really a chance to put your side. And I didn't want them to say that's the side or that's the side. All I wanted was an evaluation of the total process and the evidence. And to be honest, it felt as if we were being punished the whole time. And do you know something? There was points where I felt like the accused, and I don't believe that the team did anything to deserve that kind of position. I'm sorry, but I'm absolutely confident we did everything that we could, everything within the scope. We reported, we used the manual, we audited from the manual, we provided education, we were doing surveillance. I mean, there still isn't gram-negative surveillance now. I mean, there isn't. So we're continuing with the methodology that was given to us. And it did feel like we were found guilty before any kind of process. All you wanted was to have a fair representation of what we were. In terms of recent assurance, so HIS have come in and have done their inspection of the Queen Elizabeth in 2022, who reviewed our systems and our processes and how we were managing patients, how we were reporting infections, and they had a positive view of that. We had the board, for their assurance, commissioned an external review of our services last year. And they matched us against 6 standards. I had no recommendations in terms of patient referrals, education, how we managed the system, how we managed governance, how we managed information. There was one recommendation, it was how we capture mandatory education, and it was a system thing, but that was 6 standards and 5 were green, 1 was amber. So I feel as if that our service has been reviewed, and a number of times, I don't believe anyone's stood up and said, you've done this, you're terrible. And all I was hoping for was a fair evaluation about what we were doing. I'm sorry, didn't go on.
I have nothing further for this witness.
Ms. Devine, what I need to do now is check that there are no further questions in the room. So we'll break. I'll ask you to go back to the witness room, and I'd hope you could come back within about 10 minutes.
Thank you, my lord.
Please stand.
Mr. Connell?
I have been asked to raise 2 short questions with the witness.
Mr. Devine, I'm told that there's a few more short questions. Mr. Connell?
You may or may not be able to help us, but I've been asked to raise them with you in any event while you're here. In paragraph 546 of your witness statement, which is the part we've just been through about how NHS Assure operates, and you've offered us some thoughts on that. You explain the potential value of having a, as it were, a core of expertise available.
Absolutely.
Now, do you know whether NHS Assure offered to come in and, let me use the word inspect, have a look at Ward 2A after it had been refurbished?
I think they were part of the process. I mean, I remember conversations with Miss Critchley, and I'm sure there was colleagues from HFS and Assure in that process. I mean, yeah, I'm sure they were.
Well, the question was really focused about once you've done the work and it's geared up and you're ready to look at patients, the suggestion is that NHS Assure said, well, we'll come and have a look at it now it's all ready, and the board said, no.
I'm not aware of that.
You're not aware of that? The other question, and again, tell me if you don't know, there's an accreditation that you get for bone marrow transplant units, and I'll probably get the initials wrong, but it's JC. It's a series of, is it JACIE?
I think so.
No.
Sorry.
Anyway, it's an international based accreditation focused on these kind of specialist units, is that right?
Yes.
Did Ward 4B get JC accreditation?
I don't know. I mean, I would imagine so, but I don't know.
But
for
you don't
sure.
know?
No. I think there was a problem with the JC because when they were in the Beatson, because I think one of the standards is that they're adjacent to an intensive care unit. I think that was possibly one of the drivers for them being on the QE site. But that is just out of my memory, I'm sorry.
Are you familiar with the JACIE? I think it's IE standards.
I'm not familiar with the
No.
content of them, no.
So you wouldn't know
I think it's
what
a lot.
units are covered.
I don't know if I would be extremely surprised if they weren't covered,
Right.
but because I think I don't know that they're allowed to operate unless they are. No. But I honestly, I don't know. Sorry.
Or which countries they apply to.
I don't know that either.
Right.
Sorry.
I have nothing further to know.
Right. Thank you very much, Ms. Devine. You've answered all the questions you've been asked, and that means you're now free to go. But before you do, thank you for your attendance today, and thank you for the work that's involved in preparing a written statement. I'm very much aware that that's a lot of work. So thank you for that as well, but you're now free to go.
Thank you. Thank you.
Please stand.
We'll see each other tomorrow morning at 10.
Indeed.